Good afternoon, everyone. I would like to present a short description of the use of helifix system together with kill technique in hostile neck aneurysm using standard endurant 2 elements. What is a hostile neck? Hostile neck is a well-known description of difficult morphology in proximal landing zone in EVAR, which can be described with the acronym SWAG, which means short, wide, angulated, or conical. The definition was introduced initially in 2003 and concerning the length of the neck less than 15 millimeters, diameter more than 28 millimeters, and angulation. After that, some other features joint, like, for example, the conical shape of the neck. Why the hostile neck definition is so important? Because of the complication rate. It is proved in literature that the endoleaks occur 4.5 times oftener than in normal neck. And AA-related mortality is much higher. Sometimes it's much higher, like 9 times fold higher than in regular patients. Now, I will present a short description of the classic kill technique without using the endostaples. The first report of the kill technique was made by Mignon in 2009, and it was made with the Gore excluder prosthesis. We started to use this kill technique in 2015 with the endurant elements, with good effects, good durability. Of course, there are different methods in dealing with hostile neck problem, like chimney techniques or, for example, beaver, or of course, the best option, open repair, which is, of course, not available for all the patients we have. So this is one of the examples of difficult neck and the kill technique we used to solve the problem. As you see, the first segment is implanted subrenally, and here you can see the smooth landing zone. The first thing you can see that the angle in the original angio of the aorta is less sharp than it was. Now it's about 90 degrees. And after the implantation of main body here, the angle is even less than 90 degrees. So this is one of the reasons why the kill technique is important, because the radial force and the rigidity of the system is much higher. So in the angulations with the short neck, it is important. And here you can see the same diagram, but with the modification. So it was the natural development of the technique. We thought that another fixation and additional fixation of the kilt implanted initially will be a good option for the patient, especially with the short neck. Here you can see the staples just below the lowest renal. And it's optional. You can also, after implanting the main body, you can also implant another endostaples to fix the main body into the kilt. Now I will present one of the cases we made. This is the patient with almost 6 centimeter aneurysm with a very short neck. You can see here it's about 3 millimeters, and then there is a conical shape. So it's a classic definition of the difficult neck. There is the diameter of the neck is quite normal. It's about 24 millimeters below the renal, and at the end of the conical shape is about 30. So in the first movie, here you can see the initial angio of the patient, and here we can see the first segment opened, it's the kilt without any endostaples now. Now there will be a short movie to see how to fix the endostaples. It's the procedure, it's the same like in classical ESAR. So according to instruction for use, we follow the rules and implant the staples on the opposite side. After that, we change the angle, and then we implant another staples into opposite side also. You can see it now. You have the first implanted here and here. Then now we have right anterior oblique. We implanted the endostaple at the left, and now just below the renal at the right. It takes some time when you exchange the system because you have to reload after each screw. So this is the fourth screw implanted here, or endo anchor. And after that, we have another change of the projection. And now we'll have left anterior oblique, I think. And the last two endo anchors will be implanted according to the same manner. I mean, to the opposite sides of the graft. So after that, we can be sure that the initial segment called kilt is implanted and fixed very, very much to the aorta, to the aortic wall. So we have a very smooth and long landing zone for the main body. And after that, this is the final effect. We have kilt implanted into the aorta just below the renals. And this is the same patient after the end of the procedure. We didn't use any additional staples because there was no angulation, so there was no risk to the main body to migrate because the landing zone was smooth enough and long. So let's finish this short presentations with the conclusions. The kilt technique is very, very promising in difficult neck patients. As far as now, we have 10 patients treated with the kilt technique together with ESAR, and we have really good outcome for the patients. Of course, they are still under observation, but I encourage you to use this technique. And of course, welcome for discussion.